Hello everyone and welcome back. I'm Joe Chappelle and you're listening to episode 41 of the OBGYN podcast. Today, I am very excited to have Dr. Jillian Kurtz back with us to take us through the world of ovulation induction. This is probably the most common cause of infertility that most of us non-reproductive endocrinologists will see, and Jillian does a great job at getting behind the workup and management of the anovulatory woman. So, without further ado, let's get started with episode 41, Ovulation Induction.
Hi everybody. The last time Dr. Chappelle had me on the show, we talked about options for fertility preservation, which was really fun for me. But today I'd like to talk about something that might be a little more relevant for the day-to-day general OBGYN practitioner. So we're going to discuss approaches for ovulation induction. Population studies show that infertility affects about 15% of couples, and ovulation induction represents one of the most common interventions for the treatment of infertility, since 25% of those cases of infertility can be attributed to anovulation. When anovulation is the only cause of infertility, prognosis for pregnancy is really pretty good because our strategies for ovulation induction are highly effective. The diagnosis of anovulation can usually be established by history alone. A woman with irregular, unpredictable, or infrequent menses typically do not require specific diagnostic tests to prove anovulation. Conversely, with regular menses of average duration, anywhere between 25 to 35 days, is very likely ovulatory. If, however, you are not certain and would like a confirmatory test, a luteal phase serum progesterone is the simplest. Now, it is important to remember that this should be drawn 1 week prior to the expected start of her next period. We have ingrained in our minds to always draw a day 21 progesterone, which is appropriate for someone with a 28-day cycle, but not all women have the same cycle length. A progesterone concentration less than 3 nanograms per milliliter implies anovulation. According to Spiroff, a progesterone level greater than 10 nanograms per milliliter suggests normal luteal function, but because progesterone is secreted from the corpus luteum in distinct pulses, a progesterone level less than 10 may still be observed in a normal cycle. So once we've established the diagnosis of anovulation, now what? While PCOS is the most common cause of ovulatory infertility, the various causes are vast and include premature ovarian failure, thyroid disease, hyperprolactinemia, eating disorders, PCOS, pituitary and ovarian tumors. A new diagnosis of anovulation really warrants a thorough evaluation for an underlying cause. Often, when this is identified and treated, ovulation will resume, unless, of course, the cause of anovulation is premature ovarian failure. At a minimum, anovulatory women should be screened for thyroid disorders with a serum TSH and hyperprolactinemia with a serum prolactin. Strong consideration should be made for endometrial sampling with a long history of anovulation given the increased risk for endometrial hyperplasia. Say, for example, we find hyperprolactinemia in our workup for anovulation. The management for this person is very different from a PCOS patient. According to Spiroff, some women with hyperprolactinemia will ovulate with clomiphene, but most will not and will require dopamine agonist therapy. The two most common agents are bromocriptine and cabergoline. Both are ergot alkaloids that mimic the actions of dopamine and thus inhibit pituitary prolactin secretion directly. Friedman et al. Demonstrated that prolactin-secreting adenomas remain sensitive to the actions of dopamine, proving that these medications are effective in treating hyperprolactinemia even in the setting of a pituitary adenoma. According to Spiroff, prolactin levels should respond shortly after the initiation of treatment. The levels should be repeated in a week to evaluate the efficacy of a given dose. Around 50 to 75% of women will resume ovulatory cycles with treatment, according to a study of about 450 women published in the New England Journal of Medicine in 1994. So let's say after a thorough evaluation, we conclude that polycystic ovarian syndrome is the reason for your patient's anovulation. Dr. Chappelle goes into great depth into the pathophysiology of PCOS in his podcast, so if you haven't already listened, feel free to pause and refresh your memory on the intricacies of this complex syndrome. Let's go into a little review of PCOS and its relationship with insulin resistance. In the 1980s, the Journal of Clinical Endocrinology and Metabolism published two very important articles. The first, published in 1980, demonstrated that PCOS is associated with hyperandrogenism and insulin resistance. The second article, published in 1983, demonstrated that insulin resistance in women with PCOS was independent of obesity. It is now clear that many women with PCOS have some level of insulin resistance, even in the absence of obesity. This recognition led to many studies to investigate the role of metformin and other insulin sensitizing agents in the treatment of PCOS. One of the best insulin sensitizing agents is weight loss. Losing even 5 to 10% of body weight often restores ovulatory cycles in obese women with PCOS. Clark et al. Found that 90% of obese and ovulatory women who lost an average of 10 kilograms per meter squared, in other words, dropped 10 points in their BMI, resumed spontaneous ovulation, and 78% ultimately achieved pregnancy. Given the health benefits and the efficacy of weight loss, this is the obvious first-line option for obese women to resume ovulation. That being said, we know from clinical experience that not all women will be able to achieve weight loss of this magnitude, so we often end up moving up the treatment chain. There are quite a few studies on the effect of metformin in women with PCOS. Now, I'm not going to go into all of the nitty-gritty details of these studies, but ultimately, a systematic review of the literature published by ASRM, the American Society of Reproductive Medicine, stated that while metformin alone did increase ovulation rate in women with PCOS compared to placebo, it should not be used as first-line therapy for ovulation, as the alternative agents of clomiphene citrate and letrozole are far superior. There is fair evidence, however, that in a woman who does have some level of insulin resistance, that the combination of metformin along with clomiphene does improve ovulation and pregnancy rates. Spiroff recommends a screening semen analysis prior to initiation of ovulation induction, as male factor is an important contributing cause in 20 to 40% of infertile couples. That being said, if the male partner has fathered children and if you have very low suspicion for male factor infertility, it is not unreasonable to start with a few cycles of ovulation induction to minimize cost to the couple. If the history suggests possible tubal factor infertility, for example, perforated appendicitis, extremely painful periods to suggest endometriosis, or history of PID, then a preliminary HSG and transvaginal ultrasound are also recommended. I find the history of reproductive science super interesting, so I'm just going to spend a couple of minutes delving into that. Evidence of the pituitary gonadal axis first presented in the 1920s when it was observed that lesions of the anterior pituitary resulted in atrophy of the genitals. For the next several decades, this relationship intrigued science. In 1928, Aschheim and Zondek introduced the first pregnancy test. They found with 98.9% accuracy that when the urine of a pregnant woman was injected into a young mouse, only 3 to 5 weeks of age, the mouse ovaries would increase to 2 to 3 times their normal size. The clinically therapeutic potential of gonadotropic hormones was investigated further, and in 1938, Davis and Koff published their work, which demonstrated the ability of purified pregnant mare serum to induce ovulation when administered intravenously. These studies were ultimately stopped due to concerns for safety and efficacy, as many women developed a sensitivity reaction, presumably secondary to antibody production. However, 20 years later, Gemzell did describe successful ovulation induction preparations derived from human pituitaries, and shortly after, Lunenfold described successful ovulation induction with the use of postmenopausal urine from women. As with many scientific discoveries, the breakthrough of clomiphene citrate was found serendipitously. In the 1950s, the first nonsteroidal estrogen antagonist called MER25 was being used to evaluate the efficacy in treatment of cystic mastitis, endometriosis, breast cancer, and endometrial hyperplasia. Some of these cases of endometrial hyperplasia were secondary to anovulation and PCOS, and much to the surprise of the investigators, when these women were given an anti-estrogen, they resumed menses. Shortly thereafter, the ovulation-inducing capabilities of related compounds, such as clomiphene citrate, was recognized and approved for the clinical use in the United States in 1967. According to Yen and Jaffe, clomiphene citrate remains the most commonly utilized drug for infertility, accounting for 2/3 of all prescriptions worldwide. Clomiphene citrate acts as a selective estrogen receptor modulator that has both estrogen agonist and antagonist properties. Its structural similarity to estrogen allows it to compete with the endogenous estrogen for nuclear receptors throughout the reproductive system. Clomiphene citrate binds to estrogen receptors for an extended period of time, interfering with accurate assessment of circulating estrogen levels. At the level of the hypothalamus, circulating estrogen levels are perceived as lower than they truly are, which results in reduced negative estrogen feedback and a compensatory increased release of GnRH, which in turn drives ovarian follicular development. It has been shown to cause a 50% increase in endogenous serum FSH level. Subsequently, serum estrogen levels rise, ultimately triggering an LH surge in ovulation. Now, it's important to recognize that as a SERM, clomiphene behaves differently in the different reproductive organs and may exert less desirable side effects at some peripheral sites, including the cervical mucus and endometrium. Some studies suggest that quality and quantity of cervical mucus production may be decreased in clomiphene cycles. According to Sparrow, however, this effect is now largely moot. Evaluation of cervical mucus is rarely done in practice today, as controlled trials of postcoital testing have proved to be of little value. A second side effect to be aware of is the effect of clomiphene on the endometrium. Impaired endometrial growth has been noted in some women treated with clomiphene, though several studies have shown that the majority of women actually have normal pre-ovulatory endometrial thickness. While it is likely that there is some endometrial inhibition with clomiphene, the clinical relevance of this is a little less certain, except perhaps in individuals with very poor growth and endometrial thickness less than 5 to 6 millimeters. As a practitioner, if you are concerned about the negative effects of clomiphene on the endometrium, it is reasonable to switch to another agent such as letrozole, which is not known to inhibit endometrial growth. We'll delve into letrozole a little later in the podcast. The conventional starting dose of clomiphene citrate is 50 milligrams per day, taken on day 2 until day 5 of the menstrual cycle. Greater than 50% of the population should ovulate at this dose. However, if no response is seen, the dose should be increased to 100 milligrams per day in the subsequent cycle, followed by 150 milligrams per day, which is usually considered to be the highest dose beyond which alternative treatments are indicated. LH surge occurs between 5 to 12 days after the last day of clomiphene administration. We generally reserve the use of clomiphene citrate to treat women with ovulatory dysfunction, though there may be an argument for use in women with unexplained infertility as well. The efficacy in this population may be attributed to optimizing follicular development or by accomplishing multiple ovulation with a greater chance of fertilization. This method is most effective when combined with intrauterine insemination. While it is generally very well tolerated, it's definitely important to warn people about the side effects of taking this drug. Up to 10% of people experience flashes. Less than 2% of women will also complain of nausea, vomiting, breast tenderness, and blurred vision. But the most important side effect, of course, to discuss is the increased risk of multiple gestation, which is about 7 to 10% by several different sources. The large majority of multiple pregnancies are twins. The increased risk of multifetal gestation is another reason why we try to treat with the lowest effective dose of clomiphene citrate. The incidence of ovarian hyperstimulation syndrome in association with clomiphene citrate therapy is extremely rare, and mild cases associated with abdominal discomfort, mild nausea, vomiting, or diarrhea can be managed expectantly. Now, as we know, nulliparous women have an increased risk of ovarian cancer. The repeated ovulation with subsequent epithelial disruption and repair predisposes to the development of ovarian cancer. It makes perfect sense then that agents that would promote ovulation or even superovulation would increase the risk of ovarian cancer as well. This has not proven true, however. Several studies have shown that while the risk of ovarian cancer is increased in infertile women compared to fertile women, it is not necessarily increased in infertile women who have been exposed to ovulation induction agents. It is, however, the general consensus that prolonged treatment with clomiphene citrate should be avoided because beyond 3 to 6 months of treatment, there is little hope of success. So let's say hypothetically we have an anovulatory woman who fails to ovulate with clomiphene despite our stepwise progression as mentioned earlier. The next obvious choice is an aromatase inhibitor. These have primarily been used in the treatment of breast cancer, but are increasingly being used off-label as an ovulation-inducing agent. And actually, the most recent ACOG practice bulletin put out in June 2018 suggests that in women with PCOS, letrozole should actually be considered first line. Aromatase inhibitors, such as anastrozole and letrozole, act by inhibiting the rate-limiting step in the formation of estrogen and act both centrally and peripherally. The compensatory increase in pituitary gonadotropin secretion due to decreased negative feedback leads to increased follicular development. After treatment with an aromatase inhibitor ends, estrogen from the growing follicle quickly rises and the negative feedback resumes. This is in contrast to women treated with clomiphene citrate, in which negative feedback cannot resume as quickly due to depletion of the central estrogen receptors. So you get more prolonged gonadotropin secretion and increased likelihood for multiple follicular development. Of course, there are always exceptions to the rule, and there have been case reports published of sextuplets on letrozole alone. This leads to some reproductive endocrinologists to advocate for some level of ultrasound monitoring during any ovulation induction cycle, as it will allow the patient to be counseled on the increased risk of multiples in the setting of multiple follicular development and potentially allow for canceling the cycle altogether. As mentioned earlier, it is thought that these aromatase inhibitors do not have the same negative effect on the endometrium and cervical mucus as clomiphene citrate. They are taken in a very similar manner to clomiphene. A dose of 2.5 milligrams letrozole is taken for 5 days, starting on day 2 or 3 of the menstrual cycle. If a woman fails to ovulate at this dose, it can be increased to a dose of 5 milligrams, up to a maximum dose of 7.5 milligrams daily. Early studies suggested there may be some associated fetal toxicity, which led the manufacturer to issue a warning against the use of the drug for premenopausal women. However, 2 large studies by Tulandi and Foreman subsequently found no evidence of increased risk of birth defects in children conceived after letrozole. In 2014, the New England Journal of Medicine published a double-blind randomized control trial comparing letrozole with clomiphene citrate and found a higher cumulative ovulation and overall pregnancy rate with letrozole compared to clomiphene. This study is what prompted ACOG to encourage the use of letrozole as first-line treatment over clomiphene for ovulation induction in patients with PCOS. Now, surgical treatments for anovulatory infertile women date back to the 1930s when Stein and Leventhal performed their classic wedge resection in order to evaluate the histology of the PCO ovary and, surprisingly, restored ovulation. Laparoscopic ovarian drilling was a more modern equivalent. Electrocautery is applied to approximately 4 to 6 sites on the ovary. The subsequent destruction of the ovarian stroma, at least temporarily, decreases ovarian and systemic androgen concentrations and can help restore ovulation. Because of concerns of postoperative adhesions and potential effects on ovarian reserve, these techniques have largely fallen out of favor, but could still be seen as second-line therapy in someone who was concerned about the increased incidence of multiples with gonadotropins. All right, so we've still got to talk about gonadotropins. This method of ovulation induction is highly effective, but very costly and is associated with a high risk of complications, including multiples and ovarian hyperstimulation syndrome. There are 2 groups of anovulatory disorders that may require gonadotropin therapy. The first is hypogonadotropic amenorrhea, or WHO type 1 amenorrhea. As you guys may remember, this condition may result from severe weight loss and anorexia, excessive physical exercise, or severe emotional distress. It can be congenital, acquired, or idiopathic. The anovulation is secondary to very low or absent GnRH secretion. These women rarely respond to clomiphene and may require either pulsatile GnRH or exogenous gonadotropins. Now let's take a quick step back and review the endocrinology of the ovary. Ovarian estrogen production requires the synergistic action of 2 cells, the granulosa cells and the theca cells. Theca cells are stimulated by LH to convert cholesterol to androstenedione and testosterone. The aromatase in the granulosa cells then converts the androstenedione into estrone and estriol. In a woman with WHO type 1 amenorrhea or functional hypothalamic amenorrhea, gonadotropin treatment will need to include both FSH and LH to effectively stimulate both steroidogenesis and folliculogenesis. Now, for any listeners still in OBGYN residency, I remember this being a question asked on CREOGS. How do we elicit ovulation in women with hypothalamic amenorrhea? So just know that Clomid and letrozole will not work, and it will require both FSH and LH. The second group that may benefit from gonadotropins are the PCOS patients who are resistant to other methods and failed to respond to more conservative options we discussed earlier. This category of patients should be able to achieve ovulation with FSH alone, as they have enough endogenous LH to allow for steroidogenesis to occur, although added LH does not appear to be harmful, according to the ASRM Technical Bulletin on exogenous gonadotropins. Historically, the only exogenous gonadotropins available were human menopausal gonadotropins, which were extracted from the urine of postmenopausal nuns from a single convent in Italy. We've come a long way since then, and in the 1980s, the discovery of recombinant DNA technology would lay the groundwork for how we make synthetic FSH and LH today. Conventionally dosed protocols saw unreasonably high rates of multiples, as high as 36%, and ovarian hyperstimulation at a rate of 14%, according to Fauser et al. So now, according to the ASRM-sponsored PCOS Consensus Workshop Group, the recommended initial starting dose of FSH is 37.5 to 50 international units per day, and the dose will be increased by 50% if after 14 days no response is seen on ultrasonography, which is defined as no follicle greater than 10 millimeters having emerged. And they recommend canceling the cycle when 3 or more mature follicles greater than 16 to 18 millimeters or large numbers of intermediate-sized follicles are observed, or when serum estrogen exceeds 1,000 to 1,500 picograms per milliliter. There are no specific evidence-based guidelines for optimal timing of trigger, but it is generally accepted that a follicle, and ideally no more than 2 follicles, approaches 16 to 18 millimeters, ovulation should be induced with either HCG or GnRH agonist. This is used to stimulate the LH surge to induce the final stage of oocyte maturation. As we know, the oocyte is frozen in prophase 1, goes through meiotic maturation to metaphase 2, and this process takes about 36 hours to complete. About 4 hours later, ovulation will occur. HCG is the least expensive and most widely used trigger, and is effective due to its structural similarity to LH. A GnRH agonist can also be used, assuming this agent hasn't already been used during treatment to prevent spontaneous LH surge. For obvious reasons, the GnRH agonist will be ineffective in a patient with hypothalamic amenorrhea, but is the preferred trigger anytime there is increased risk for ovarian hyperstimulation syndrome. Now, you may wonder, in the setting of hypothalamic amenorrhea, if the root of the problem is lack of or diminished GnRH, why don't we just administer the missing agent? As you may recall, GnRH stimulation occurs in a pulsatile fashion. In the luteal follicular phase, pulses occur every 90 to 120 minutes. This slow pulse frequency in the setting of low estradiol and inhibin levels favors FSH secretion. In mid-cycle, GnRH pulse frequency increases, favoring LH secretion. In order to mimic our physiology, GnRH therapy requires wearing a programmable mini pump hooked up to an IV or sub-Q catheter for an interval of 2 to 3 weeks or longer. It does have some advantages in that it does not require monitoring and does not have the same risk of multiples associated with gonadotropins. But the cumbersome delivery system or technical problems with the pump deters women from using this method, and they opt instead for gonadotropins. While the GnRH pump is available for use in other parts of the world for this purpose, it is still not available in the US, though there are clinical trials currently underway with the NIH. That pretty much wraps up this topic of ovulation induction. I know that was a lot. Thank you for sticking with me.